Okay, so hello, and we are here to discuss a few previous year questions in this session of the topic pedodontics. All right, so yeah. So in this session today, I have very carefully chosen some questions which are, based on clinical decision making. I have chosen some questions that are based on facts that you need to learn. There is no logic application there, some factual questions. Again, I've also chosen certain image based questions, and there you might also encounter a few questions in today's session where you will know that sometimes you get questions where the options are confusing. You feel like this is also correct, that is also correct, which one should be the more correct option, which one should be marked. Okay, so I've included such questions also. So, without wasting a lot of time, let us begin with the first question of the session today, which is, in this image below, identify which procedure is being done. So I want you all to carefully notice this particular picture. Here you will see that there is a filling over here. There is something at the root end over here. There is a structure over here, and the tooth seems to be a permanent tooth, a permanent anterior tooth. Okay, there is one more thing that I want you all to notice in this picture. So the root end of this particular tooth, the root end of this tooth here clearly is not closed. It is not completely formed. So we can safely say that the root end of this tooth is open. Okay, so this is a young permanent tooth. So what all have we noticed? We've noticed that this is a young permanent tooth. Why? Because one, it is permanent because you cannot see an underlying what you call as the tooth bud. Secondly, it has an open apex, an incompletely formed apex. Okay, this particular structure that you are seeing over here is nothing but a rubber dam clamp. Okay, so what exactly is this thing, this root end filling? So what they've asked is identify from the image below what procedure is being done in this picture. So whether it is an MTA apexification, whether it is some kind of a root end filling, whether it is apexogenesis, or whether it is a root canal treatment. So very, very easily we can know, because it is a young permanent tooth, the apex is open. It is not just any any root end filling which is done for a post and core procedure. It is in fact an MTA apexification. It is an MTA apexification. Okay, so the answer here is A, that is MTA apexification. So now, since the tooth is a non-vital tooth, you can safely say by looking at the picture there that the tooth that has been given is a non-vital tooth, because the entire, all right, so it is a non-vital tooth because the entire canal of the root seems to be empty. That means there is no vitality in that tooth. It is a non-vital tooth, and it is associated with a periapical lesion. Okay, so if I rub all this mess, you can easily notice that there is a good amount of periapical lesion present over here. So can you see the clear radiolucency around the tooth, around the root apex, which is an abscess that is formed also, which we can call it as a periapical lesion. Okay, so it is a non-vital tooth. It has a periapical lesion, and the treatment opted will undoubtedly be an apexification. So what is an apexification? It is a procedure that is done in a young permanent tooth where you have an open apex. So the tooth has become non-vital. You have to do a root canal treatment, but in a root canal treatment you are supposed to fill the root, you are supposed to obturate the root. But in case of a young permanent tooth with an open apex, you will not have a stop to your material which you use for obturation. Like for example, if you're using gutta percha, there will be no stop. The apex is open. The apex is something like this. This is an open apex. Okay, this is all running here and there. Yeah. So this is an open apex. This is your tooth. Okay. So this is the open apex. Yeah, so if there would not have been a trauma, or if it would not have become caries, the root would have developed like this and completed. Okay, this is how it would have completed, but it did not, because before the completion of the root there was a trauma or carious lesion. So since it is an open apex, so what will happen if you do a traditional root canal treatment, you will not have a stop for the obturating material. Hence you need to do a procedure such that you form a barrier at the apex, and hence it is called as fixing the apex, which is also called as apexification. So that is the meaning of the term apexification, that you are creating a barrier, or you are fixing the apex so that you can obturate very easily. You get a stop for the obturation procedure, right? So apexification is a method where you induce a calcific barrier in the root with an open apex, or continued apical development of the teeth with incomplete roots and necrotic pulp. Okay, the process of empty apexification. So why like when you use calcium hydroxide or metapex, you just fill in the root canal, and then there is a bridge, there is a calcific bridge that is formed at the root end, and then later you remove all the metapex or the vitapex or calcium hydroxide, and with the support of that calcific bridge you do a complete obturation. But in case of MTA, what is done is, the process of MTA involves placing mineral trioxide aggregate plugs in the apical portion. So what you do here, you're supposed to place MTA plugs, right? You're supposed to place MTA plugs in the apical portion of the canals. So it is placed in the apical portion of the canals. So like how you can see in the diagram, there is a plug-like structure that is placed on the apical portion of the root canal, and the thickness of that apical plug should be around, so this is very important, please take a note of this, it should be around 3 to 5 mm. The thickness of that apical plug made out of MTA should be 3 to 5 mm, followed by a conventional root canal obturation with gutta percha. So here I want you all to listen very carefully. Whenever you do apexification with calcium hydroxide or metapex or vitapex, what you do, you stuff the material, one of these materials, in the root canal, and then you wait for like several months together, and then you ask the patient to come for follow-ups, take x-rays, and one fine day you will be able to confirm that there is a calcific bridge that is formed over there. So now you can safely remove that material, vitapex, metapex or calcium hydroxide, and with that calcific barrier you can complete the obturation. But in case of MTA, you are not supposed to place the material and wait for a long time. You can just place the MTA in the apical region. You can observe it with the help of radiograph. So you place a plug as thick as 3 to 5 mm in the apical region, and immediately after that you can do the obturation using gutta percha. So there is no waiting time over there. Okay, so that is how MTA obturation is done. So MTA is mineral trioxide aggregate. I hope all of you all know. I'll still write it down. So what is MTA? MTA is mineral trioxide aggregate. Okay, so while the other materials that have calcium hydroxide as the component, they will induce odontoblasts from the blood cells and the live tissues to form a calcific barrier. MTA is more of a physically setting material that does not disturb the live tissues or odontoblasts or anything. It will just set like cement at the apical region. So it will just set there, and immediately after that you can place gutta percha and do the what do you call as the obturation, right? So the answer here is MTA apexification. I hope it is clear to you all. The difference between MTA obturation and obturation using calcium hydroxide or materials made out of calcium hydroxide. Okay, the second question now that we are going to read is, discrepancy in the anterior primary and permanent spacing is called. So what happens is, so whenever you have a primary dentition, whenever we are talking about the primary anterior teeth, so they are small teeth, okay. So for example, these are the primary teeth over here. They have a natural gap occurring in between them. So I'm going to draw it like that. So these are the primary teeth, whereas the permanent teeth are huge. Like, 6-7-year-old children, when you see them with freshly erupted, what do you call as permanent anterior teeth, they look scary almost. The parents will come with so much of concern. Why does my child have such big new teeth? So these new big teeth are really big. So these are big. They do not have a gap in between them. So you have to tell such parents that let your child grow, let the face grow wider, the teeth are going to look normal. Okay, so that's another thing. But the question that is being asked is discrepancy in the anterior primary and permanent teeth is called what? Like this is the anterior permanent teeth width and this is the anterior primary teeth width. So what is that discrepancy called? It is called as incisal liability. So the answer here is incisal liability. It is not arch length discrepancy. It is not arch length tooth size discrepancy. It is not incisal labiality. So here I want you to be very, very, careful. Like you see option A and D, you will almost get confused. In option A, it is written incisal liability, and in option D, it is incisal labiality. It's like here and there, spelling. So be very careful in reading the spelling also. First thing you see option D, yes, this is option D, this is incisal liability, you'll take a correct answer. But that will go wrong. So you must be very careful in such cases to read the spelling properly. So the answer here is incisal liability. Now, what is incisal liability? Incisal liability means that the amount of space that you need to have, or what is liability? It is the liability over the arch length to accommodate the permanent incisors. Okay, the primary incisors are so small, and in place of those primary incisors, the permanent incisors have to erupt. Now it becomes a liability. How are we going to accommodate such huge incisor teeth in such a little space? So that becomes a liability. So how does this liability is gotten over? How does the the arch width and the arch length copes up with this liability, or how is this accommodated? I'll tell you how. So the first thing that happens is change in incisor angulation. Now the incisors, the primary incisors, for example, these are the primary incisors. Please excuse my horrible drawing skills. So these are the primary incisors over here. So primary incisors are like the angle in between the primary. This is the angle, okay. So the angle in between the primary incisors is 150 degrees. Okay, so when the permanent incisors erupt, they erupt at a lesser angle. They erupt with a little more proclination. So the permanent incisors will probably erupt like this. Okay, so I'm making really bad diagrams. Yeah, so like this, and the angle becomes 123 degree. So just imagine if something is like this, so it is occupying a little more space as compared to when something is like this. Okay, so a part of the incisal liability is coped by the lesser angle, the reduced angle of inclination in the permanent teeth as compared to the primary teeth. So while the primary teeth are present at an angle of 150 degree, the permanent teeth are present at an angle or at a proclination of 123 degrees. Clear? The permanent anterior teeth are larger as compared to their primary counterparts, and thus they require more space. So this difference is coped up with the help of the change in the inclination degree, as I told you. And secondly, what happens? They use up the physiological spaces. There are various physiological spaces that are present all over the mouth. So they are present in between all the teeth. So they use up that. So one, the use of physiological spaces. Two, change in inclination. So there will be a change in inclination. And 3, there will be an increase in intercanine width. Okay, so these three things will happen, and these three things will help in accommodation of the huge size of the permanent incisors in place of the small size of the primary incisors. So that is how incisal liability is scoped up. Okay. Now question 3 that is being asked is, 7-year-old child comes to you with a lingually erupting mandibular incisor. So I want you to be again very careful with this question. So you have a 7-year-old child, okay, and the child comes to you with lingually erupting mandibular incisors and retained deciduous incisors. So the deciduous incisors are still retained, like for example there are deciduous incisors, and from inwards, that is lingually, permanent incisors have started to erupt. They are, you can see the incisal edges of the permanent incisors. What should be the treatment? So what all options they've given you? They've given you wait and watch till the deciduous incisors fall off. Okay. The second is extraction of the primary incisors and then you observe. Okay. Option C is extract the deciduous teeth and give an appliance. And option D is wait and watch till the lower incisor eruption is completed. Okay. So the answer here is option number D, that is wait and watch till the lower incisor eruption occurs. So what generally occurs is majority of lingually erupting lower central and lateral incisors are self-correcting. Okay, so that is the pattern of eruption. The lower incisors have a tendency of erupting in a little backward or in a lingual direction. Okay, so it mostly is self-correcting till the age of 8 years. The tongue usually positions the permanent incisors forward into the normal alignment. Okay, they tend to erupt a little lingually, but the tongue has the tendency of pushing it into normal alignment. Also, increase in lower intercanine width, that is around to average 2 to 3 mm increase will occur in the lower intercanine width. It will compensate to accommodate the lower permanent anterior teeth. If it is not corrected by 8 years of age after lateral incisor eruption, no further increase in the lower anterior intercanine width will occur. So basically, if the labial migration of the permanent lower incisors has not occurred by the age of 8.2 years approximately for central incisors and approximately 8.4 years for the lateral incisors, then extraction of the deciduous teeth should be considered. So what you're going to do, you will just wait and watch. No need of going for a deliberate extraction. You wait and watch till the lower incisors erupt, and you wait till 8 years or 8.5 years. Once by then the primary teeth will automatically fall off, and the lingual positioning of the permanent teeth will get auto-corrected by the push of the tongue. If the incisors do not fall off even by the age of 8.5 years, then you need to go and extract them, and that is why option D is the correct answer. That means you have to wait and watch till the lower incisor eruption is completed, and then the primary teeth will automatically shed off in its time, and the tongue is going to push it into proper position. So that was question 3. I hope it was clear to you. The next question, that is question 4, says that 4% glutaraldehyde for pulpotomy is applied for how much time? So for how much time are you going to apply 4% glutaraldehyde if you are doing the pulpotomy procedure using glutaraldehyde? So the answer here is 4 minutes. That is C. So C, that is 4 minutes, becomes the correct answer. So best clinical result will be obtained by the use of a 2% solution with an application time of 5 minutes. Greater success is anticipated if you use a 4% solution of glutaraldehyde for 4 minutes or a 2-minute treatment time with 8% of glutaraldehyde solution. So now you know, if you are using 2% glutaraldehyde solution, then you need to keep it, you need to apply it for 5 minutes. A 4% you will use for 4 minutes, and 8% glutaraldehyde solution you will keep just for 2 minutes. So there the answer becomes C, that is 4 minutes. The next question here is, what is K-swallow used for? So K-swallow is a kind of an exercise. It is a kind of a tongue exercise. Is it clear? So K-swallow is a kind of a tongue exercise which is used for treating retained infantile swallow. So the answer here is B, that is retained infantile swallow. All right. So what exactly is a K-swallow exercise, or also called as tongue strengthening exercise? So it is basically used to correct the, okay, so are you asking? All right, I am going to get to your this thing. Let me complete this question. So basically K-swallow exercises are used to correct the infantile swallow. They are also used to correct or increase the range of movement in the tongue and help in the swallowing or speech functions. So what exactly is done in a K-swallow exercise? So you use a tongue depressor. You've seen a tongue depressor in ENT clinics and everything. You would have seen a tongue depressor. So using a tongue depressor, first what you do, you at the tip of the tongue, you press the tongue depressor at the tip of the tongue, and you, with the help of, and you try to push back with the tongue. So here you're applying a force on the tongue at the tip, and from here you're trying to lift up your tongue. That means you're giving a reverse force onto the tongue depressor. Okay, to exercise so that becomes the exercise of the tip of the tongue. To exercise the middle part of the tongue, put the tongue depressor towards the middle of your tongue, and again push up against the roof of your mouth. So you need to push it against the tongue depressor. Then to exercise the back of your tongue, where should you actually place the what do you call tongue depressor? So you say K. So whenever you say K, there is a portion of the tongue, the posterior tongue, that touches your palate. So that becomes your posterior part of the tongue, and wherever that touches the palate, there you will put the tongue depressor, and again you will try to squeeze your tongue against the tongue depressor or try to lift it. Okay, so that after that you sweep the tip of your tongue from the very front of your mouth to the back along the floor of your mouth. So that's a kind of an exercise where you roll your tongue backwards. And lastly, you lateralize your tongue from one corner of your mouth to another. So this is the entire drill of that tongue exercise. And a patient who has a retained infantile swallow, or a person who needs to help with speech, should do this drill of the tongue exercise, also called as the K-swallow exercises. So this is how it is continued with. So I am getting a few questions over here. All right. So, okay, there is a reference question. So, I think I will address to this question on the Telegram group only, because all of you all cannot see the question. So, I am going to address to these questions on the Telegram group. Let me quickly finish the questions that I've sorted here, and then I'll get to your questions on the group. Okay, so the next question in here is, all of the following effects are observed with the use of calcium hydroxide in pulpotomy except. So what all effect is not observed with calcium hydroxide? So antimicrobial effect, yes, the effect is there with calcium hydroxide. Alkaline pH, of course, calcium hydroxide has an excellent and a very high alkalinity. Tissue dissolving, No. So, and coagulative necrosis? Yes. Whatever part of the tissue that comes in contact with calcium hydroxide undergoes coagulative necrosis. So, the answer here becomes tissue dissolving property. So, all of the following are observed with the use of calcium hydroxide except means which of these is not a property of calcium hydroxide. So, option C, that is tissue dissolving, is 100% not a property of calcium hydroxide. Hopefully it is clear. So basically the properties of calcium hydroxide for pulpotomy, the first is antimicrobial activity of calcium hydroxide is attributed to the ionic dissociation of calcium and hydroxyl ions, the hydroxyl ions being lethal to the bacteria, because it will the hydroxyl ions that are present in calcium hydroxide will have three basic mechanisms. That is, it will cause damage to the cytoplasmic membrane, they will also cause damage to the DNA of the bacteria, and again the hydroxyl ions will result in protein denaturation. So let me quickly write it down. So the hydroxyl ion will result in three things, that is damage to cytoplasmic membrane, all right. The second is if they will cause damage to DNA. So here we are talking about the bacteria, the damage is being done to the bacteria. And the third thing that it will do is it will cause protein denaturation. Is it clear? So these three things are done by the hydroxyl ion of the calcium hydroxide. So hence it becomes antimicrobial. Okay, then calcium hydroxide helps in mineralization and repair due to its high pH. A superficial layer of necrosis is observed and it acts as a stimulant for hard tissue formation. Okay, when in contact with the vital pulp, so you are placing calcium hydroxide directly on the vital pulp when you're doing a pulpotomy or a direct pulp capping. So it causes coagulative necrosis beneath the calcium hydroxide due to its high pH. This change is accompanied by acute inflammatory changes in the underlying tissue. After 4 weeks, a new odontoblastic layer and eventually a dentine bridge is formed and your work is done. Your pulpotomy or direct pulp capping is successful after that. So tissue dissolving property is definitely not one of the properties of calcium hydroxide. So the answer here becomes tissue dissolving, that is C. The next question, the seventh, is what is the ICDAS score in the image that is given below? So the ICDAS score here is 6 and 6. So the answer is B, that is score 6 and 6. So let us quickly brush what is ICDAS scoring. So ICDAS scoring is so in order to grade the severity of dental caries, we use the ICDAS scoring. It has a code from 0 to 6. It can code the caries or grade the caries from a point 0 to a 0.6. So 0.0 obviously means a very sound tooth surface with no caries change even after air drying. So there's a tooth, there are no visible caries, you air dry the tooth, there is no there is no matte patches or white opaque patches, nothing, no hypoplasia, no wear erosion, nothing. So that becomes score 0. Then there is a score 1. So in score 1 we have the first visual change in the enamel seen only after air drying. So just like that, if you see the tooth clinically, you will not be able to appreciate any degree of demineralization or any degree of cavitation, nothing, no discoloration. But when you air dry such a tooth, you will see that there is an opaque patch over there, so seen only after air drying, or color change. If there is a color change, like if it is stained by some food or something, then you'll call it as a brown spot. So the change is thin, limited to the confines of the pits and the fissure areas only. So that becomes score 1. Then we have score 2. So in score 2, there is distinct visual change in the enamel seen when it is wet, white or colored, wider than the fissure or the fossa. Okay, then there is a score 3 where you can see localized enamel breakdowns. Now this is the beginning of cavitation. So here in score 3 you will be able to see localized enamel breakdown with no visible dentine or underlying shadow, discontinuity of the surface enamel, widening of the fissures. So the fissures will look a little widened, there will be discontinuity of the enamel, but there is no dark dentine that is being exposed right now. Then comes score 4, so where you will see underlying dark shadow from the dentine with or without localized enamel breakdown. Okay, so that is score 4. Then we have score 5. So in score 5, distinct cavity with visible dentine is seen and frank cavitation involving some part of the tooth is seen. So that is, so here in score 5 you will be able to see the cavitation very frankly. You will see, like, when you use a hand instrument, you will be easily able to appreciate that there is disintegration of enamel and dentine. Whereas when we talk about the score 6, so that shall mean that there is extensive distinct cavity with dentine, involving dentine, and the cavity is deep and wide and it involves half to more than half of the tooth structure. So that becomes score 6. So here when you see in this picture, there is distinct deep wide cavity over there in both of the teeth. So the answer here becomes score 6 for both of the teeth. Okay, so that completes our question number 7. And for this, I've just verbally told you about the ICDAS codes. So you can refer to my lectures or join my live lecture now that we are going to stream to in detail see about the ICDAS scoring with pictures and everything, so that we're going to cover in our lectures. Alright, so the next question here that I've included is question number 8, that says trauma to tooth with pain but no mobility or displacement is called what? So so what they've asked is, there is trauma to the tooth, there is pain but there is no mobility, like, there is trauma, somebody's punched you in the teeth, so the teeth have not become mobile, but there is pain in the teeth and there is no displacement also. Your tooth is right there, no mobility, no displacement, but there is pain. So that is going to be called as concussion. Okay, so concussion, I'll give you a very good example of concussion. Like, it would be happening with you a lot when you were kids. Like, you're walking and suddenly you will hit your ankle with it on a table. Okay, and then your ankle, that part of your ankle will turn a little bluish red and then it is going to pain. So that's concussion. Concussion is an injury that is that occurs due to a trauma by a blunt object. Okay, so that's called as concussion. So in concussion, what will happen? The PDL fibers will get compressed, the PDL fibers will get hurt, and that is why there's going to be pain in the teeth, but they've not broken, so there's no mobility and there is no displacement. Is it clear? Okay, so concussion, basically the tooth is tender to touch or tapping, it has not been displaced and does not have increased mobility. Right, then what is subluxation? So subluxation means the tooth is tender to touch or tapping and has increased mobility. Luxation, that means the tooth has moved from its place. Okay, so it will be tender to touch and has increased mobility. So there is mobility over here, mobility. Yeah, but it is not displaced in subluxation. There is bleeding from the gingival crevice, whereas when we talk about luxation, the tooth is displaced only. Okay, so it is displaced from its position, and it is usually palatal or lingual or labial, from whatever direction the trauma has occurred, opposite to that direction there will be shift of the, what you call as, the tooth. Then we have extrusion. So extrusion, you all very well know, extrusion means coming out of the tooth. The tooth looks elongated, it has come out of its socket a little, so that's extrusion. And if it has gone into the socket a little, it will become intrusion. So these are all the different types of trauma to the teeth, but the answer here is concussion, where there is no mobility, no displacement, just tenderness to percussion. Is it clear? So the next question here is, partial pulpotomy is done with the help of all except. The answer here is laser. That means D, laser. So we have actually found a lot of references for that answer, but that suggests that laser is the least accepted treatment. The entire roof of the pulp chamber is removed using the high speed non-end cutting burr with copious water spray. So that means you're using this. Okay, the coronal pulp is amputated using a 6 or 8 number round burr. Okay, that is a slow speed burr using a coolant. So that means you're using this. And then later you can also use a spoon excavator in order to, you know, excavate all the coronal part of the pulp. So you're using all three of these. So according to McDonald's and Avery, they recommend basically amputation of the pulp to be done with the use of only spoon excavator. There are various others that say that low speed burrs can be used with coolants in order to, you know, de-roof or remove the coronal part of the pulp. An extensive review that has been done, and it concludes that laser assisted pulpotomy, there is weak reliable evidence that lasers are effective more as compared to conventional pulpotomy. So the answer here becomes laser. All these three can be very well used in the conventional procedures of pulpotomy. Hence, we choose high speed rotary burr with coolant, followed by low speed with coolant, as well as use of spoon excavator for a conventional pulpotomy procedure, and lasers are least preferred treatments. Is it clear? The next question here is again an image based question which says, what is shown in this picture? So this picture, the options that have been given to you is whether it is a lateral luxation, or it is an avulsion, it is subluxation, or intrusive luxation. So as you can see in the picture, the tooth, so this is the tooth, and the tooth has shifted sideways from its position. The tooth, neither it looks shortened, neither does it look elongated. So 100% it is not intrusion, not extrusion. And since it has moved sideways from its position, so the answer becomes so the answer becomes lateral luxation, that is A, lateral luxation. It is not avulsion, because avulsion will mean that the tooth has come out of the socket completely in toto. And subluxation, as we just read, subluxation means that it has become mobile, but it is not displaced. But in the picture here, you can very clearly see that the entire tooth and the socket, everything is displaced to a corner. Okay, and then again, it is not intrusive luxation or intrusion, because the tooth length does not look shortened. The tooth crown length appears to be normal, so it's not extrusion. So the answer here is lateral luxation. So here I want you all to know that how you will, you know, discard the rest of the options, how you are going to reach to the correct option. I hope you understood why B, C and D are not the right answer for this image based question. Okay. next question here is crescent shaped white spot lesion after complete drying of anterior teeth of a young child is related to what? So it is a crescent shaped white spot lesion. You've dried the anterior teeth of a young child and then you've seen it. So what can be the answer here? So the answer here is it is a beginning of early childhood caries. So basically, the white spot lesion is the initial clinical detection of demineralization. So this is an initial detection of demineralization. Mineralization. Right, so a white spot lesion will show that there is initial remineralization and in the enamel, and it is defined by enamel demineralization of the subsurface. So there is demineralization in the subsurface. That's why the opacity is reflected with increased porosity owing to the mineral loss onto the outer surface. The carious lesion is frequently reversible at this point. So at this particular point, you can still remineralize the particular lesion, and it is a solvable problem. You can reverse this particular stage. The next question here is, so sometimes 2 to 3 year old babies tend to collect food in their mouth and enjoy swallowing very, very slowly. So that's the problem of so many mothers, that he does not, finish off the food from his mouth very quickly. What is the reason for this? So the most primary reason that every mother attributes to is laziness. So the child is simply lazy, he does not want to chew and swallow the food, he just wants to roll it around in the mouth. So yes, that's one. But a more scientific and relevant reason is one of these. Okay, so what exactly is the answer? So here the answer is C, that is the muscles of the floor of the mouth and mastication are not so much in a harmony in such small children. So how much ever you scold them for being lazy, this is also one of the problems with them. The muscles of the floor of the mouth and the muscles of mastication are not in harmony. So basically this particular phenomena is called as food pocketing. Alright, so this phenomena is called as food pocketing, and the most common reason is simply that they lack the sensory awareness or the tongue coordination to fully chew and swallow certain foods. So it takes a little greater time for them to assess that the food is ready to be swallowed. So that's called as food pocketing, and that's the reason why they will take a very long time to swallow the food. Am I clear? The next question here is most common material used to fabricate a mouth guard. I hope you all know what is a mouth guard. So mouth guard is basically an appliance that is worn by children either to prevent sports injuries, like children who are practicing boxing, karate, taekwondo, stuff like that, or skating and all. So they will wear mouth guards in order to protect their teeth from injury. Also, children who have habit of nighttime bruxism, we fabricate mouth guards for them so that it does not generate TMJ problems and it does not result in attrition of the teeth. So that becomes useful for such children also. So what is the material that is used to fabricate a mouth guard? So the answer here is ethyl vinyl acetate, EVA. So there are mainly two types of mouth guards. The most commonly used is the mouth formed mouth guard, which costs less and is made by the user after softening it in hot water, forming it in the mouth with the pressure of the fingers. So you soften it, place it in the mouth, and with the pressure of the fingers you make it, you with the help of the tongue and the cheeks you try to mold it better as is the situation of the oral cavity. Most mouth guards are sold worldwide are of this type only. The second type is the custom made mouth guard, where you first take an impression and with the use of various machines that are present, you fabricate a mouth guard that is custom made. So there are various government organizations that have sports grounds and everything. There you will generally find first type of mouth guards that are quickly fabricated in the mouth of the patient only. The performance of the mouth guards can be determined in three ways. The energy absorption of the material. So you need the mouth guard to perform. They should not be a blob of rubber or plastic sitting inside. So how do you assess the performance of the mouth guards? The energy absorption of the material from which the mouth guard is formed can be gauged. So the energy absorption can be gauged. The resistance to deformation can be measured, like how quickly does it get deformed, and again the wearer comfort. So on these three grounds you can judge a mouth guard, like how much energy does it absorb, how fast will it get deformed, and third is how much the wearer is comfortable with that particular mouth guard. So these are the three grounds on which you measure it. Okay, the next question here is about the sucking reflex. All are true except one of these. So the answer here is it persists up to 4 years. So that's not correct. So it is an important primitive reflex. Yes, it is. It is not learned. Inherently, it is present in Homo sapiens. Yes, that's a correct statement as well. It is the process of sucking which leads to contraction of the smooth muscles and leads to milk ejection. Yes, that's also correct. But the wrong statement here is that it persists up to 4 years of age. So the sucking reflex is said to be seen in utero by the 3rd month of the fetal life, so that by the end of the gestation it can put to use. So isn't it very surprising and magical that when the child is only 3 month of a fetus, not even outside, 3-month-old fetus will develop a sucking reflex, so that by the time the child is ready to be born, this particular reflex is ready to use. It is considered an appropriate feeding response of the newborn in the newborns. The rooting reflex and the sucking reflex work together in order to feed the infant. So what is rooting reflex? It is basically a sensation. Like for example, a child is so attentive to this reflex. Like if you touch something on the cheek of the child will immediately bend his or her mouth towards that particular touch in order to start sucking. Okay, so that's called as rooting reflex, and then again he will hold that particular thing in the mouth and then the sucking reflex will begin. Okay, so this basically helps in breastfeeding or bottle feeding. So that's called as a sucking reflex, but it does not persist up to 4 years of age. As soon as the teeth start erupting and as soon as the mature swallow starts developing, the sucking reflex becomes weaker. Is it clear? The next question here is, the first tooth that is affected in ECC, that is early childhood caries, is which one? So amongst the options that has been given, the first tooth that is affected in early childhood caries is the maxillary central incisor. Okay, ECC में mandibular central incisor does not get affected because again it's one of the immune teeth. There is the function of tongue going on around it, so it does not get carious so easily. Again, molars get affected later, but the first tooth that gets affected is the maxillary incisor. So they're typically the first ones, followed by the maxillary and the mandibular molars, and mandibular incisors are frequently spared because of the protecting nature of the tongue. Alright, so that's there. The next question here is, which of the following is wrong about gum pads? So you know what are the gum pads. So when you look at the gum pad, basically it can be, let me draw it for you so that it is going to be easier. So if this is the maxillary gum pad, so this is the maxillary gum pad. So here we have the incisal papilla. Okay, then there is a groove that runs over like this, and this is called as the dental groove. All right, there is a groove over here that separates the palate or the tongue from the alveolus, and that is called as the gingival groove. Okay, then we have various transverse grooves over here. So there are transverse grooves that make home for the tooth buds. So these are the transverse grooves. All right, then there is a bigger groove that is a transverse groove only, that is present in the canine region, and that's called as the lateral sulcus. Okay, so that's the lateral sulcus. So this is how a gum pad is present. So what have they asked us? Which of the following is wrong about the gum pads? So transverse grooves are 10 in each arch. Yes, that's the right answer, because as I told you, transverse grooves are supposed to make rooms for the future tooth buds. So there are going to be 10 teeth in each arch, so there will be 10 transverse grooves in each arch. So that's a correct statement. Maxillary and mandibular gum pads are in posterior contact. Yes, you have I hope you remember from our lecture that anterior open bite is present in the gum pads, because the mandible is present in a very retruded and underdeveloped position. So the maxillary and mandibular gum pads contact only in the posterior region. So this also becomes a correct statement. The maxillary is a horseshoe shaped arch. Yes, the maxillary arch is a horseshoe shaped arch. So that's also a correct answer. But option B, that is the dental groove divides the palate and the gum pad, is the wrong option. That's the gingival groove. So option B is the wrong statement. So that becomes the correct answer. I hope that is clear to you all. All right. So the next question over here is, pre-operational stage in Piaget's theory of cognitive development is around. So when does the pre-operational stage come in the Piaget's theory? So the answer here is 2 to 7 years. So that's called as the pre-operational stage. So whenever we look at the 4 different stages of cognitive development in Piaget's theory, we see the first is sensory motor stage. The second is pre-operational stage. The third is concrete operational. And the fourth is formal operational stage. So these are the 4 stages that are present in Jean Piaget's theory. So sensory motor stage is from 0 to 2 years. Then we have pre-operational, that is 2 to 7 years. Then there is 7 to 11 years. Concrete operational, and formal operational, which is 12 years and above. So these are the 4 different stages that are present in Jean Piaget's theory, and they've asked us about the pre-operational stage, which is 2 to 7 years of age. So the next question is, material not used for pulpotomy is, which of these following materials is not used? So MTA is used for pulpotomy. Glutaraldehyde is also a material that is used in the process of pulpotomy. So is ferric sulfate. But maisto paste is not used for pulpotomy. It is an obturating material. Maisto paste is an obturating material. So it is used in case of pulpectomy. Okay, it consists of parachlorophenol, it consists of camphor, menthol, iodoform, zinc oxide, thymol, and lanolin. So these are the components of maisto paste, and it is an excellent obturating material used in pulpectomy procedures, but not in pulpotomy. Is it clear? Now you have this image based question again. Which of these pictures will give rise to a class 2 occlusion in permanent dentition? So which of these is going to lead to a class 2 occlusion? So the answer here is option C, or the figure C. This is going to lead to a class 2 occlusion. So it is basically nothing but a distal step occlusion or distal step occlusion of primary molars. So distal step occlusion or distal terminal plane is unfavorable as it guides the erupting permanent molars into class 2 malocclusion with minimal differentiation growth. Okay, so as you all know that Baum had classified the primary molar occlusion into flush terminal plane, mesial step and distal step. So this is a distal step, this is a flush terminal plane, and this is a mesial step occlusion pattern of a what do you call as primary molars. Okay, so this basically distal step will lead to a class 2 molar occlusion when it develops into a permanent, or what do you call as permanent teeth. So the distal surface of the lower second deciduous molar is distal to the, so this is distal to the upper second deciduous molar, and the permanent molars may erupt into an Angle's class 2 occlusion. So this leads to our last and final question of today's session, and that is, while preparing a class 2 cavity on lower primary molar, patient complains of sharp pain which subsided after few minutes. What will you do next? So you're preparing a class 2 cavity, on a lower primary molar, that means a lower D. The patient suddenly complains of a sharp pain, but it gets subsided after a few minutes. So what are you going to do? So the answer here is inform the parents of an iatrogenic exposure, and you will have to do, so RCT is falsely written here, you'll have to go for a pulpectomy. So you'll have to go for a pulpectomy if there is a sharp pain. So patient experiencing a sharp pain which subsides after a few minutes is a classic condition of irreversible pulpitis. Alright, so the question does not mention whether it is iatrogenic exposure or just a pain while drilling. So in either case, if there is irreversible pulpitis, we will have to do some sort of a invasive procedure, that is either pulpotomy or pulpectomy. Here pulpotomy, though it will be ideal because it has just pained and subsided, so we can assume that only the coronal part of the pulp would be inflamed. But since pulpotomy is not given in the option, so we will consider a root canal treatment or a pulpectomy as the correct answer, because inform the parents of iatrogenic and do direct pulp capping. A condition of direct pulp capping will never elicit sharp pain. So direct pulp capping is a complete no-no, because sharp pain, that means the pulp is more extensively inflamed, at least the coronal part of the pulp is involved. Option C says inform the parents of iatrogenic exposure and extract the tooth. Why would you? It is a healthy tooth with healthy roots, no need of extraction. Option D is fantastic. Do not inform the parents and continued with the planned treatment. So do not do that. The patient has had pain. That means there is inflammation in the pulp. So you have to treat the pulpal inflammation. So ideally you should have gone for pulpotomy, but since there is no option that says pulpotomy, so you're going to go for an RCT or a pulpectomy, and that makes option B as the correct answer. So these were the questions that I chose for you all for today's session, and the few image questions that you have posted on the Telegram group, I am going to reply to you the solutions of it right away on the group itself. So please keep posting questions. I hope today's questions were helpful. You got to learn the approach of how to solve the clinical questions, the confusing ones, and if there is any more doubt, any more problems relating specifically to these questions, please message me or write down in the comments. And thank you so much. Bye bye. Good night.